patient, as a consumer. He has put a lawsuit of 7 crores to the hospital for not being able to marry, not being able to have a fruitful family life after having been detected positive, and that's because of somebody did not carry out probably a safe injectable practice on him. That just happened very recently. Like this, you will hear a lot of more lawsuits because of unsafe practices on injections. So how to get it right? All of us write down policies, protocols, processes for IV therapy. These are very well written in almost all hospitals. These are easily available on various sites, in various manuals. Most of it remains written only. What we write in the protocols, what we write as policies, are not either well understood by the caregivers, by the nurses, or they do not appropriately focus on those policies. So what we write on paper in the policies and protocols is not actually what we practice. When you hire a nurse, she has already learned the IV therapy, IV practices from various hospitals to undo what she has not learned right and to put the right protocols into her practice is quite a difficult task. Hence, ladies and gentlemen, it is my plea that when you write policies and protocols, involve the caregivers and let them understand, let them be part of designing the process so that they will implement it better, they'll implement it more appropriately. Control the environment. We always lack space. We do not have appropriate designed and designated spaces for medication management. A lot of hospitals do not design a medication room or a designated, dedicated medication space. So if your workplace is cluttered, you are working in the same nursing station environment, doctors are coming, phones are ringing, relatives are visiting you, asking you questions, and in the meantime, you are also engaged in your IV therapy, you are diluting a drug, you are verifying a drug, you are labeling a drug, and you are expected to be accurate there. It is quite not possible. Hence, having an uncluttered place for medication management, for your IV preparation and dilution is one of the most important to avoid distractions. Know and use the right equipment. As we just said, hospitals have moved forward to modern management of infusion therapies. You need to invest money and effort in terms of acquiring and procuring the right equipment. This is an era of smart pumps. There are n number of smart infusion pumps available. Technology is available, and more you engage with the industry partners, you see there are devices which can monitor the patients in the rooms even on a IV drip. You can come across these partners, acquire smart pumps which are not dependent upon human errors, but which are more automated. Once you set, it delivers the right dose, the right quantity, in the right time, at the right flow. And also you can track patients. You will see in hospitals which function in terms of patient rooms. A nurse is taking care of 5 to 7 or 8 patients on a floor. For her to keep a track when the intravenous fluid in the patient room is going to finish, and to avoid further complications of a backflow, of an air embolism, etc., can be avoided if, as hospital administrators, we invest in those devices which can give you alerts at the nurse station on your hospital information system that this fluid is going to finish in next 15 minutes. Hence, the nurse has ample time. She can go back and she can change the IV fluid or discontinue or stop the IV fluid. It is humanly not possible for a nurse to keep a track of so many IV infusions, blood transfusions, parenteral nutritions, which are happening, and she is able to take care of it. So this is something about smart pumps. We have customized software to create libraries which can be doctor specific, which can be department specific, which can be hospital specific, and it does not depend upon a human error, as I just said. A nurse can easily program it, and it is an automated device, and you can manage your infusions better. As for a pharmacist view, as nurses, we are not very well educated in terms of identifying medications which are coming every day, new medications, new antibiotics, third generation, fourth generation. It is not really possible for us to remember everything. Every hospital has a pharmacy unit which is functioning round the clock. Do not hesitate, friends, to take advice from the pharmacy if you have little element of doubt. It is always better, and most hospitals with NABH and JCI have actually moved to a process of verification of prescription by the clinical pharmacologist or clinical pharmacist so that you can avoid prescription errors. Confirm the order. Whenever a prescription for an IV infusion is written or entered into the CPOE, confirm the order and access information about the patient and drug. Confirmation of a doctor's order and verification by an independent second person are two things which we must do, but we do not carry out very well. In my own organization, I have created, we have a hospital information system, which is a proprietary of Columbia Asia. We have created a field of second person verification. Believe you me, the nurses hate that feature, and they hate me for it. They think a single nurse is going to give medication, why she herself cannot just give, why she has to call a second person to actually verify on system. For them, it is wasting time. But imagine if a second person, independent person, verifies the dose, the dilution, the time, the patient, it will add value. It will take away majority of your administration-related errors. So this is something which most of the quality initiatives say, identify the patient with at least 2 ways. And the 2 ways should be a unique number as well as the name of the patient. There are hospitals which practice a bed number, a room number. What JACO says, JACO recommends before you administer a drug, a nurse must know age, sex, the present medications of the patient, diagnosis, comorbidities, other conditions, lab values, allergies, and sensitivities. Do we really focus on knowing so much of it? We do not. When you go and interview nurses on the floors, in ICU they might be aware of comorbidities, they might remember allergies, you might find an allergy band, but just having an allergy on another drug-to-drug interaction, what mechanism do we have available to our nursing team to check if there is a drug-to-drug interaction? It is not written along with the prescription order. So if a doctor has prescribed a drug, he's prescribed multiple drugs, and there are drug-to-drug interaction, how will the nurse get to know this? You need to design and devise a support system for the nurse, so the moment she checks a prescription, she has a mechanism to log into SIMS, MEMS, Lipin code. There are n number of vehicles available. The hospital has to invest money on that. So if there is a drug-to-drug interaction or there is a drug and food interaction, the nurse sees an alert and she can alert the doctor and the medication can be changed. So do not use the errand-prone practice of identifying patients by room number, bed number, and do use barcodes on armbands or RFID bands, what we can use on the patients. But again, from my personal experience, we have devised barcoding system for identifying patients, identifying drugs, identifying medical consumables, but nurses hate scanners and they hate to scan the barcodes. So these are safety measures which are designed for absolute patient safety. Kindly use it. Use a labeling system. So when you are using multiple drugs, you are loading one drug, another drug. After you verified the drug, verify the patient, kindly label the first medication, only then move to the second one. These practices may be very good on floors and in the ICUs, but when you've got emergencies, when you're working in the operating room, in the cath lab area, usually these practices can get missed out, and hence you can end up having errors. So did you remember to document all medications given? Did you notice there are 2 patients with the same name? You can make errors with, especially in same state. In Bengal, you will have Mr. A. Chatterjee, Mr. B. Chatterjee, Mr. C. Chatterjee. In Karnataka, we will have Mr. A. Joseph, B. Joseph, C. Joseph. Don't just remember patients by name. You need to use the second identifier to ensure you are giving medication to the right patient. Obtain an independent double check. It adds a lot of value, and it is clearly said it can detect about 95% of the errors. Hence, move on to the verification very strongly. Double check is a must. No matter how much you are experienced, you need a double check. It adds a lot of value, can take away 95% of your errors. Decide if you should give the drug. If you have any doubt, please ask yourself, should your patient be getting these drugs? Is it right? Are you thinking there is some confusion about the prescription? Are you thinking that some wrong dispensing has been done by the pharmacy? Is the drug looking right? Is the color looking right? Are you able to see the expiry date? Can you track the batch number through your barcoding system? Open communication. We need to create a culture where nurses are absolutely free and comfortable asking questions in terms of verification of drugs from their seniors, from the doctors. Maybe you can create a helpline number for the nurses. The helpline number may belong to a senior nurse supervisor or to a pharmacy level person, where this nurse can call for support as a helpline number, should I be giving this drug? It may be a look-alike, it may be a new drug, she does not know about the drug, so create some helpline, a mentor. Check for adverse reactions. On adverse reactions and incident reporting, we heard a great session from Mala. So kindly look for reactions, pick up the reactions pretty fast, report it to the treating doctor, report it as per your protocol, but report it immediately so that you can take combative measures immediately without any delay. Report significant changes. Non-punitive approach. We all say we do not penalize anybody. If we do not penalize anybody, why are nurses scared to report? Why are doctors scared to bring it up? Why do nurses and other healthcare givers, including doctors, team up together for hiding incidents? Why are we not able to disclose it to the patients? There are times when family members, companions, they tell to the hospital administrators, I'm telling you, the nurse gave me twice insulin, once before my lunch and once after my lunch, because before lunch you had the morning nurse, after lunch you had the evening shift nurse, but kindly do not terminate their jobs. So please do not have a punitive approach. It does not work to correct the system. So in conclusion, make safety your top priority. Move from a culture of blame to one of safety culture. Re-engineer your processes. Stop blaming people for making errors, because it is usually a process failure or a system failure, and it is not an individual failure. Improve the system. Redesign the system. Utilize technology. There's so much happening in healthcare technology, healthcare informatics. Do not depend upon an old age system, traditional system of doing a handwritten prescription and reading it, making mistakes from a 10 to 100 units. Involve patients and their family members to the fullest extent, and you can avoid a lot of errors. Communication with patient and family adds a lot of value. Measure and iterate and refine. I'll take a few moments in terms of what is happening in India in terms of infusion safety. I represent Infusion Nursing Society of India. This is an initiative which started 5 years back in India. It is a INS US affiliate chapter in India. And the sole purpose of this body, Infusion Nursing Society of India, is to actually bring awareness improvement strategies for infusion safety in the country. We have come up with INS India with voluntary organizers, nursing administrators, couple of industry partners, and I'm glad to say Captain Usha Banerjee, she's part of our GC Council. Miss Mary Jose is part of our GC Council, and maybe some of you sitting here may be part of the General Body Council, which has been part of forming the infusion nursing standards. We have also come up last year in the month of November with the standards of practice. It is a book which has been launched in India for the first time on standard of practice for infusion therapies. This is a book, it is available online. You can buy it through the Infusion Nursing Society of India. It gives you standards and which get upgraded every 6 months. These standards are getting upgraded. And a good news is these standards have been recognized and acknowledged by the Ministry of Health. We had that news published that INS standards have been recognized, and we would want to advocate that these standards actually reach the nursing colleges where students are undergoing their final year training, so that every fresh graduate who comes out of the colleges is actually a trained infusion nurse. By the time she takes over her first patient, she's already a trained infusion nurse. We are also moving on to National Data Repository. What you don't track, you can't improve. Apollo is part of the National Data Repository. They've already started sharing the data. Not just Apollo, many of the other hospitals in India have come up. And if any of you sitting here want to be part of this, we'll be very glad to take you, because we want to come up with some research and improve infusion therapy overall in the country. Way together is the way forward. Today is Dr. Abdul Kalam's birthday. I thought we must acknowledge his focus on education and coming up together for improvement. Thank you very much. I'll be glad to take the questions end of the session.